And this puts us into the situation that was highlighted by the CARD study. And that was a major study that was published in the New England Journal of Medicine within the last year or so. And this was one where they really wanted to go and study whether or not we should do cabazitaxel or whether we should do another AR-targeted drug in this setting. So the CARD study enrolled patients on a one-to-one fashion who had previously received a therapy, who had previously received docetaxel and had already received either abiraterone or enzalutamide. And they were randomized to receive cabazitaxel at 25 milligrams per meter squared every 3 weeks, which is one of the dose regimens that we can do, or the other AR-targeted therapy. So in this case, if we were enrolling this patient onto the CARD study, he would be randomized to receive either enzalutamide or cabazitaxel. So it's really testing the second AR-targeted drug versus chemotherapy. And this is a really important question because many, many patients, and we know this now because these drugs have been approved for a long time, and I've done it for many years as well, many patients will cycle through AR-targeted drugs because they're generally well tolerated. And if a patient is developing resistance to abiraterone, why not try enzalutamide? But the reality is what we know now is that that second AR-targeted drug is generally ineffective. Part of the reason we know that is because of the CARD study that we're talking about right now, but we've also seen some other data, prospective studies, where patients were switched from one to the other to try to see if sequencing was actually beneficial for these patients, and there was not much of a benefit seen in that setting. So anyway, back to the CARD study, there were 255 patients who were randomized, and after a median follow-up of about 9 months, there were 74% had experienced progression in the cabazitaxel arm, and 80% had experienced in the other arm. And that was a statistically significant finding. So these patients in the CARD study were really testing a very advanced group of patients, symptomatic, many of them, and already resistant to one taxane therapy and an AR-targeted therapy. The median overall survival, which was published in the New England Journal of Medicine, was 14 months in the cabazitaxel arm and 11 months in the AR-targeted arm. So getting right to the point about this patient, should we put him on enzalutamide or should we put him on cabazitaxel? His survival is going to likely be better with the cabazitaxel. One of the issues that comes up is what are the likelihood of response in this setting to either one of these therapies? Along those lines, we really saw quite a significant difference. For many, many studies, what we've seen is that the second AR-targeted drug, the response rate is generally in the 10 to 15% range. So very, very low. Very few patients in this setting will have a reduction in their PSA that's meaningful. In this setting, however, we have about 36% of patients who have a PSA decline of 50% or greater, and 36% have a shrinkage in tumor, radiographic shrinkage in tumor for those who had the liver mets like he does, or soft tissue mets on lymph nodes, et cetera, et cetera. The CARD study was fairly definitive in demonstrating with a level 1 degree of evidence that cabazitaxel would be the right choice for third-line treatment in a case like this. From a toxicity perspective, adverse events were generally equal. They were a little higher in the cabazitaxel arm, 56% versus 52% in those receiving the AR-targeted drugs. We really didn't learn anything more from the CARD study about the adverse events of cabazitaxel or any of the AR-targeted drugs. There were no surprises in terms of the adverse events. With cabazitaxel, especially in the second-line setting like this, second-line chemotherapy setting like this, we're going to need to be expecting some marrow suppression and possibly the need for growth factor support, et cetera. And keep in mind also that many patients who start out on 25 milligrams per meter squared can do just fine if we reduce their dose to 20 milligrams per meter squared. So those are the considerations, and that's where we are with the status of second-line chemotherapy in this setting. And I, for one, was very grateful to see the CARD study prove in a prospective fashion that the sequence in this setting should be towards further chemotherapy.